Namaste, future doctors. Welcome. Today, we are starting a very, very important chapter, Chapter 65. I'm telling you, this is crucial for your exams and for your entire career. We are talking about immunosuppressants. You can think of them like a double-edged sword, a talwar, with two sharp sides. On one side, there are these miracle drugs that make organ transplants even possible. But on the other side, well, that's where the real challenge for a doctor begins. Chalo, let's get started. So just imagine this situation. You're in the OT, you have just completed a perfect kidney transplant. Everything went by the book, a total success. But then the patient's own body, the very system that's supposed to protect it, starts to attack this new life-saving organ. This, right here, is the central problem, the paradox that we as clinicians have to solve. Our own defense system becomes the enemy. Okay, so to understand how we fight this war, we first need to understand the battlefield. In medical terms, we call this the host versus graft reaction. It's simple, right? The host is the patient's body, and the graft is the newly transplanted organ. It's a full-on internal battle. And let's be very clear. Your immune system is a fantastic soldier. It's brilliant at its job. It sees a new kidney and immediately thinks, enemy, the same way it would see a dangerous virus or bacteria. It will launch an all-out attack to destroy this invader. So our job, which sounds a bit crazy, is to intentionally weaken our own best defender just to save that new organ. Right, so now let's talk about our weapons. Our very first line of defense, what you can think of as the heavy artillery, are the corticosteroids. These are the powerful, old-school drugs we've been relying on for a very long time. So how does this heavy artillery actually work? Well, it's a full frontal assault on multiple fronts. First, they inhibit the MHC expression. Basically, they're telling the cells to hide their identity cards so they can't be recognized. Then they stop the T lymphocytes, our immune soldiers, from getting activated and from multiplying. And they cause something called lymphopenia, which is a rapid drop in the number of lymphocytes, by basically pushing them out of the blood circulation. It's a really powerful, multi-pronged attack. And this point here, you have to remember this for your clinical postings. It's a must. If you're on your rounds and you see the signs of acute rejection in a patient, what is the first thing you do? High-dose IV corticosteroids. Immediately, you have to hit that rejection hard and fast to stop the attack in its tracks. But you see, a broad attack, like with that heavy artillery, it causes a lot of collateral damage. So modern medicine has given us something better, precision missiles. We call them biological agents. Let's see how this changes our strategy from just brute force to a much more targeted approach. This slide here, it tells the whole story of modern immunosuppression in one sentence. We're moving away from, carpet bombing the entire immune system. Now we use precision strikes that target the very specific communication lines, the molecules and the receptors that are actually fueling the rejection. It's much, much smarter medicine. Okay, pay attention now. This table is exam gold. You have to know this. Look at how these drugs work. They aren't just shutting everything down. No, they are intercepting specific signals. For instance, infliximab blocks TNF-alpha, which is a key inflammatory molecule. And look at basiliximab. It only targets the CD25 receptor, which is found only on activated T cells. Not all of them, just the activated ones. See? That's the precision strike we were just talking about. Now let's look at one of the originals in this category, Muramona B CD3. Here's an easy way to think about it. If the T cell is a security guard, then the CD3 molecule on its surface is like a part of its radio receiver. Muramona B CD3 is a monoclonal antibody that comes and basically puts a block on that radio, so the T cell can't receive the attack signal. Simple, right? No signal, no attack. Okay, pens down, everyone, listen to me. This is a favorite exam question data, so listen carefully. When you give the very first dose of Muramonab CD3, the body kind of freaks out. The antibody binds to all these T cells at once, and that causes a huge, massive release of inflammatory cytokines. Things like TNF-alpha, interleukins. What does the patient feel? High fever, chills, basically classic flu-like symptoms. This whole thing is called cytokine release syndrome. You must remember that name. So we have this whole arsenal of weapons. Heavy artillery, precision missiles. How do we actually use them? We don't just fire randomly, henna? Good medicine needs a good strategy. In transplantation, we follow a very clear three-phase playbook. This step-by-step approach shows you how we change the intensity based on the situation. Phase 1, induction, happens right around the time of the surgery. It's very intense, heavy-duty therapy to prevent that early aggressive rejection. Phase 2, maintenance, is for the long term, maybe lifelong, using lower doses to find that perfect balance. And Phase 3, the anti-rejection regimen, is what we deploy when, despite everything, an acute rejection episode actually starts. So what happens if those high-dose steroids in the anti-rejection phase fail? Do we give up? Never. We escalate. We bring in the rescue therapy, our big guns, like miramonab CD3 or another one called antithymocyte globulin or ATG. But this victory is not free. There's always a price to pay. And every single one of you must understand this fundamental truth. Suppressing the immune system is like making a deal, and there are always consequences we have to manage. This slide shows the tightrope every transplant doctor walks every single day. If you lean too far one way, not enough suppression, you lose the organ to rejection. But if you lean too far the other way, too much suppression, you leave the patient completely defenseless against all kinds of infections and even cancer because their immune system is no longer on patrol. And this, my dear students, this is the true art of medicine. This is what you will spend your entire careers trying to master. It's not just about looking at the numbers on a lab report. It's about that one patient sitting in front of you. Finding that perfect balance for them, that is our ultimate duty. So I will leave you with this question. All the research, all the new drugs that are being developed, it's all in service of answering this one single thing. Think about it. That's all for part 1 of this chapter. Study well, and I will see you all for part 2.